When I think of tuberculosis, I think of high security quarantine and full body protection suits, like a scene from a film. That's because tuberculosis is a highly contagious infectious disease that isn't often seen of or heard of within Australia. The infection is caused by a bacterium called Mycobacterium, which is a rod-shaped aerobic bacterium with a thick waxy cell wall to prevent anything penetrating the cell. The infection is transmitted through airborne droplets caused by coughing and sneezing of the infected individual. These bacteria-containing droplets commonly enter healthy subjects through portals of entry such as the nose and mouth, causing a cascade of immune responses which can lead to an infection. I now have an epidemiology professor from New South Wales Health here to highlight the effects of tuberculosis in Australia and globally. So would you like to start, Professor, with where tuberculosis is found?
Generally, tuberculosis is found globally, but the infection is most prevalent in Africa and Asia, in countries like India.
Okay, so it's still quite an issue in terms of infection control. Can you highlight where Australia is faring with those statistics?
Awareness and preventative measures have enabled Australia to maintain one of the lowest rates of tuberculosis globally. However, in 2018, approximately 1,400 new cases were reported in Australia, with 513 cases being right here in New South Wales. Furthermore, Aboriginal and Torres Strait Islander people are 6 times more likely to contract tuberculosis than non-Indigenous Australians.
Speaking of high-risk demographics, can you outline to us some of the risk groups that are more susceptible to tuberculosis?
People with weaker immune systems are more likely to contract tuberculosis if exposed to it, but we find that patients with HIV are more likely to develop tuberculosis at an increased rate of 20 to 30 times more compared to a person without HIV.
It seems quite significant when you put it that way. But what proportion of Australians are actually likely to contract tuberculosis?
This primarily depends on the immediate environmental conditions and the individual person's immunity, but essentially 86% of cases reported in Australia of tuberculosis are from the overseas-born population.
Generally, tuberculosis develops in the pulmonary system, or the lungs. That's because airborne droplets are often inhaled by healthy subjects. Mycobacterium then lodge throughout the upper airways. Mucus-secreting goblet cells are the body's first line of defence. They are designed to trap the bacteria and move upward via cilia for removal and destruction. Bacteria that evade this mechanism then move to infect the alveoli. Macrophages are stimulated to engulf the mycobacteria through the innate immune system. The mycobacteria has a special ligand which signals to the macrophage receptor to eat it. Once phagocytosed, the bacteria can become latent or progress to an active form. Latent tuberculosis is an inactive state of infection, where the complete elimination of the mycobacteria is not always possible. This is the most common clinical manifestation of tuberculosis. The infection can become active in later stages of the patient's life due to a health outcome that reduces their immunity, such as HIV, uncontrolled diabetes, chemotherapy, or smoking. While in its latent form, patients are not infectious and often won't experience any symptoms of tuberculosis at all. If reactivated or not initially controlled, tuberculosis progresses to an active form called primary progressive tuberculosis, which only occurs in 5 to 10% of tuberculosis cases. Within the macrophage, the bacteria continue to multiply. An immune response is initiated and can take up to 12 weeks to fully elicit the response. With this comes many enzymes, antigen-presenting cells, and cytokines. Granulomas, or what can be thought of as little jails, start forming around the bacteria to reduce their replication and decrease their spread. Sometimes this is enough to contain the bacteria in a latent form if the patient's immune system is intact. However, in most cases, the mycobacteria adapt and mutate to the situation to evade host response, whereby they create an environment that weakens the wall of the granuloma, enabling bacterial discharge to spread to extrapulmonary sites. Active tuberculosis doesn't often progress to this stage, however, when it does, patients can be expected to experience non-specific symptoms. Weight loss is caused by the wasting of lean and fat tissue due to reduced appetite and changes to metabolism from the immune response. This response, coupled with decreased body energy stores, can cause extreme fatigue. Tuberculosis patients often have a cough lasting longer than 3 weeks that can begin as a dry, non-productive cough, developing into a productive cough in later stages. This productive cough causes coughing of blood and sputum known as hemoptysis. Due to decreased alveolar gas diffusion, patients will often also have clubbing of the fingernails. 20% of tuberculosis cases progress from pulmonary infection to extrapulmonary tuberculosis. These extrapulmonary sites commonly include the pleura or lining of the lung, lymph nodes, the abdomen, genitourinary tract, and the skin.